When you think about businesses that are selling through the roof, like Skims or Allbirds, sure, you think about a great product, a cool brand, and great marketing. But an often overlooked secret is actually the businesses behind the business, making selling and for shoppers buying simple. For millions of businesses, that business is Shopify. It's home of Shop Pay, the #1 checkout in the world. You can use it to boost conversions up to 50%, meaning way less carts going abandoned and way more sales going through to checkout. Upgrade your business and get the same checkout Allbirds uses. Sign up for your $1 per month trial period at shopify.com/income, all lowercase. Go to shopify.com/income to upgrade your selling today. Shopify.com/income.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies, and I'm excited to offer you another installment of our podcast from the vault. So I'm bringing back some of our most listened to, most talked about, most commented on podcasts, dusting them off, taking them off the shelf, and re-releasing them to you. So this one is Failure to Progress in Labor with Dr. Nicole Calloway Rankins. Failure to progress in labor. Can we all agree that is probably the worst name, but it can also impact someone's view of their ability to birth. So I'm really excited to unpack this whole understanding of failure to progress. So let's talk a little bit about what we're going over in this podcast. So Dr. Rankins defines failure to progress. And then we talk about how using that term of failure to progress can really leave the birthing person feeling like their body failed them, which is not how we want someone to leave their birth. We talk about the explanation of what's called the Freidman's curve. It's a study that was done, I believe, like 50 years ago from a very small group of people. And that for many years determined how people expected labor to progress. Now, what is good is that ACOG, American College of Obstetrics and Gynecology, a few years ago, came out with some new protocols about failure to progress, but now we have to wait for some care providers to pick up on that. Transitioning from one protocol to another can take years. So we talk about the importance of fetal position and waiting longer, factors that can influence a long labor, and so much more. You can see why this is one of the most favorite, most listened to conversations, because it is brought to you with a sense of kindness and empathy and understanding. And Dr. Rankins is really so knowledgeable. So let me tell you a little bit about her. So Dr. Nicole Calloway Rankins is a board-certified practicing OBGYN and mom of 2 who empowers first-time parents to feel supported and prepared for pregnancy and birth. Over the last 18 years, she's helped thousands of babies come into this world and has demystified pregnancy and childbirth for thousands and more through her 5-star rated All About Pregnancy and Birth podcast, which I had the honor of being on. She also has an amazing free online birth plan class and her signature online program, the Birth Preparation Course. And Nicole has been on the podcast. I think this is maybe her 3rd time. Dr. Rankins is so knowledgeable. I love any opportunity to pick her brain. So this is one of my favorite conversations with her, and I'm really excited for you to hear that. Before we get to that conversation, I always love to give updates about what's happening at Prenatal Yoga Center. And truthfully, the best way to find out our latest ongoings is checking out our website, prenatalyogacenter.com. We've got our schedule of our in-person classes, our online classes, our in-studio workshops, our on-demand workshops, and of course, it keeps you up to date on everything happening with our renowned 3-month prenatal yoga teacher training. We offer it 3 times a year online, 1 time in person, and of course, once a year we do our online postnatal yoga teacher training. So it's in depth, it sparks sparks curiosity and conversation. It's something I'm so very proud of. And then before we wrap this up and get to my conversation with Dr. Rankins, I always like to take a moment and just thank you, the community, for listening and creating this community and what we are. I also want to say I appreciate the emails I have received with ideas of topics for podcasts. Some people volunteer their birth story, which I absolutely love, and other people have some ideas of guests that I should look into. So thank you for your input. It really helps this podcast not just be about what I'm curious about, but really shapes what the community wants to learn about. So thank you for your input. Okay, we're going to take a super quick break. When we come back, please enjoy my conversation with Dr. Nicole Rankins.
Have you ever spotted McDonald's hot, crispy fries right as they're being scooped into the carton? And time just stands still. Ba-da-ba-ba-ba.
Hi, Nicole. Welcome back.
Hi, thank you for having me again. I'm so excited to be back.
I know. I'm just really thrilled to speak with you. I know the 2 times we've talked with each other, it was just really a great conversation. So thank you. And as I was saying before we started taping, you get the heavy hitter conversations. The first one was due dates and induction, now failure to progress. Like these are pretty weighty. So I'm excited.
Yeah, me too. Me too.
For those that didn't listen to your first podcast episode with Yoga Birth Babies, which they should, can you tell people a little bit about yourself and what led you to obstetrics?
Sure. So, Nicole Rankins, I'm a board certified practicing OBGYN. I still practice. I've been in practice for 15 years now. That's hard to believe. And I initially actually started out thinking that I knew I wanted to do obstetrics or OBGYN because I wanted to take care of women. Initially thought that I wanted to do GYN cancer care actually, and just had a change of heart and realized that I just love delivering babies. I fell into a hospitalist position. So I work as an OB hospitalist. 99% of what I do is on labor and delivery and birth, and I absolutely love it.
So does that mean you're not on call the way someone that has their own private practices?
Correct. I don't have a practice. I don't have my own patients. Actually, you can't schedule an appointment with me. I just take care of whoever happens to be on labor and delivery while I am there. This is a new thing that's getting more and more common in OBGYN, is this hospitalist phenomenon where it's doctors who work only in the hospital. So yeah, I don't have call per se. I work 7 24-hour shifts every 4 weeks. So roughly 1 or 2 times a week I'm in the hospital, and the rest of the days I have off to do other things.
That's actually kind of amazing when you look at that, because I was thinking about when I used to be a doula, I would have chunks that I was just always on call. Like I couldn't make plans. I would sometimes be carrying my doula bag around with me, like ready to go. And it seems like this is actually a much more feasible lifestyle that, yes, they're long shifts, but you can plan your life around it.
Exactly. Yeah. Yeah. So I have, my girls are 11 and 13. So I don't think I've missed anything with any of their school events or important kind of things. I can move things around. So it allows that flexibility and allows me to do other things like have a podcast and those kinds of things as well.
And I mean, you do a lot. It's not like you're just sitting there thinking, what should I fill my time with? No, you do a ton. So, all right, let's jump in to failure to progress. I guess we should start with defining. What does that mean to label someone failure to progress?
I hate that term. I actually never use it.
Okay.
It's an outdated term that we need to stop using. What it means essentially is that your labor has stopped and you're not making any more, your cervix isn't dilating anymore, or the baby isn't descending in your pelvis anymore, but essentially labor has stopped. And we have concluded that baby is not going to come out of the vagina, so not going to have a vaginal birth, and recommend a cesarean at that point.
So what are some of the factors that lead to that? I know I'm totally jumping the questions I gave you, but I just wanted to go with that.
Yeah. So I think we have to step back and say, like, what is it? How do we get to that point?
Yeah.
First, of saying that we've called it a failure to progress. I even hate saying it. So I say arrest of labor,
Okay.
meaning that labor has stopped. So arrest of labor, or even more specifically, arrest of dilation, or it's arrest of descent where the baby isn't descending in the pelvis. Most often it's arrest of dilation where the cervix isn't dilating, or both arrest of dilation and descent. Or sometimes it can be what's called second stage arrest, where after you get to be completely dilated and you pushed for 2 or 3 or 4 hours, sometimes longer, and baby isn't coming, then it can be second stage arrest. And some things that can contribute to that are the position of the baby. And the two biggest things I would say, position of the baby and the size of the baby relative to mom's pelvis, are the biggest reasons that often labor doesn't progress.
And couldn't it also be the baby could be big, but then the way it's coming into the pelvis, or if someone is kind of sedentary or the pelvis is just not having this opportunity to open, that can compound the two reasons that things aren't progressing?
Yeah, when I say position of the baby, I mean like how, not just like, it really just how the baby is navigating mom's pelvis, and tiny little tweaks in the way that the baby is descending into mom's pelvis can make a difference as to whether or not a baby will fit or not. And we can often make those tweaks better if mom is mobile during labor, or we do things to open up the pelvis, and make more space in the pelvis for the baby, for sure.
Do you find that in your hospital, people show up with things like peanut balls, or do you guys offer that?
I happen to work at a very progressive hospital, the last one I worked at too. So we have peanut balls. All of the nurses are trained in spinning babies techniques. So we encourage motion and encourage different positions in order to help facilitate babies getting in the most optimal position for birth.
That is amazing that your nurses know that. I just was at a spinning babies all day workshop. I was the only yoga teacher and the only person that wasn't an L&D nurse. And it was actually really exciting to hear that, to see so many L&D nurses learning that technique. Because when I was working as a doula, I was pretty much alone with the client. Maybe it's because I was there that the nurses weren't involved, but it wasn't really consideration back then of, all right, is the chin tucked in? How is the baby? Yes, the baby's head down, but what else is going on that can make a difference with how baby navigates? So It's really exciting to hear there's been progress in that.
Yeah, I think more and more hospitals and L&Ds are understanding that the nuances of labor and how those position changes can make a difference. And spinning babies is becoming more popular. It's slow, but it's definitely happening.
Yes, things are definitely slow, because that leads me to my next question. I was going to talk about Freidman's curve, talking about slow changes. So can you explain what the Freidman curve is and how that became standard, as well as how it still is being standard in some places to judge labor progress?
Sure. So Freidman's curve, Freidman was a doctor at a hospital in New York, and he plotted the labor course of about 500 birthing people.
That's not very much.
And plotted how long it took them to go through labor and to make cervical change. And that curve from those women that he studied became the standard for how we judged whether or not labor was progressing or not. And there were some problems with that. One, as you said, it's a small sample size. And two, it's a homogeneous population of people. They were all at the same hospital, similar providers. But for years, that was the standard. ACOG has since come out and used something called the Safe Consortium for Labor data and said that we should not use the Freidman curve anymore, that it's outdated, and more contemporary data shows that we should wait much longer. It used to be like if you didn't make any cervical change in 2 hours, then that was considered labor arrest.
From the start?
Once you got to 4 centimeters.
Okay.
Yeah. So once you got to 4 centimeters, once you get to 4 centimeters, that was considered active. If you didn't make change in 2 hours, then it was C-section. And newer data has shown that that is not enough time at all, and we need to give much longer before we decide that labor has arrested.
I do know some hospitals still are sticking to the Freidman's curve. Is it just you think things are just slow?
Yeah, there's no other reason for that than just outdated practice and non-evidence-based practice. Unfortunately, things in medicine sometimes take, sadly, even decades for it to be common practice, things that we know are evidence-based, and this is one of them. We should have long ago, ACOG has said, and ACOG is the organization, American College of Obstetricians and Gynecologists, that sets our kind of national standards for care. They have long since said that we should not use the Freidman curve, but some people just can't seem to let go of it or aren't staying updated on contemporary and more robust data.
And that's unfortunate because we're talking about trying to practice evidence-based medicine. And then the downfall is that people might be ending up with cesareans or labeled failure to progress. And imagine the emotional impact that has of failure, and it might not have been necessary.
That 100% still happens, unfortunately, that people, I didn't make change in 2 hours and people are saying you need a cesarean birth. I think that's getting less and less, especially as trainees coming out are understanding this newer data and information. I think we're getting there, but there's still some physicians who've been in practice for longer periods of time who will stick to that 2-hour rule. And people are getting cesareans despite not really being in active labor.
That makes me sad. What is considered normal labor? And when I wrote this too, I had it in quotes. I'm like, what is normal? Like, it's just so varied.
Yeah, I think it's easier to define like abnormal labor,
like
so to
the
speak.
fast
So
ones
really,
and the really slow ones.
Yeah, it's whatever labor results in a vaginal birth. To be honest with you, is normal. And sometimes that may be like in the beginning part, it can be hours before you get to active. And then it may be really slow change in the active part. So after 6 centimeters, it may take, 5 hours, 10 hours before the baby's born. It's really hard to define what's called normal. We have to expand our definition. I think the important part is to acknowledge that we have to give it time before we say that it's not normal. And really it should be at least 6 hours of no change before we consider even thinking about like 6 hours of change and 6 centimeters dilated and water's broken before we start to say that this vaginal birth is probably not going to happen.
And that you mentioned the 6 centimeters. So I think it was, and please correct me if I'm wrong, was it 2 or 3 or 4 years ago, something where ACOG switched it from considering active labor being at 4 to 6 centimeters?
Yeah, so it was, maybe it was 3 years ago. It's I can't remember. It might have been longer than that, but it's a document called The Safe Prevention of the Primary Cesarean Delivery. And it lays out that it should be 6 centimeters of dilation to be considered active labor.
So I remember speaking with a care provider for the podcast, and he was saying it shouldn't even be declared failure to progress until at least 6 centimeters entering active labor. So that was the idea behind ACOG's new rule or new protocol.
Mm-hmm. Correct.
All right. That makes a lot more sense because that also can give people a chance to let their body kind of rev up. I remember my own first birth was days, and my midwife was just so kind about saying you're slow. It's like slow progress. There is progress. It's just super slow. And I know that had I been in a different setting with a different care provider, things would have ended up very differently.
Right. Yes. We really just don't traditionally give labor enough time to progress. And, really nobody should be getting C-sections at 4 centimeters like that, unless sometimes it happens that you do an induction and literally you've tried for like 4 days with everything that you've given it and like nothing is happening. And then you have a discussion that literally we have nothing left to offer, then that's a different story. But it shouldn't be like you came in and you were 4 centimeters dilated and then, 4 hours later we're like, well, you haven't changed, so you need a C-section. That's not active labor.
So this might be dipping the toe slightly into augmentation, but so say someone does present at 4 centimeters and then you're working with them. What are some of the things, you said like a 4-day induction and you've tried everything. What might be some of those things that you pull out to try to get things going?
Sure. So if you came in and you're in, the early part of labor, 4 centimeters, having contractions, but, and the first thing is time. So I would say I would recheck probably in 6 hours or sooner if the birthing person wanted to be checked, but probably not for at least 6 hours. And then if you were still dilated or still 4 centimeters at 6 hours, then we can talk about, well, we can wait more time if you want to, or and during those 4 hours, I would encourage people to move around, to walk, birthing ball, those kinds of things, to stay mobile if they're not having an epidural. If they want to get an epidural, pretty soon, then we try things like where the nurses take over doing position changes, peanut ball, that kind of thing. So movement, whether it's we're moving or the birthing person herself is moving, some movement is important during that time. And then medical things to do. Really, at that point, we only have a couple options, and those are Pitocin and breaking your water. And really, that's it. Those are the 2 tools in our tool bag to help move labor along once you're once you're dilated. So.
Yeah, it's not like you need a Foley bowl, you're past that point. So
yeah, exactly.
What for you in particular? Do you prefer breaking the water or pit or both? What's kind of or does it all depend really? It
really just depends. There's not. It's not a recipe or a cookbook. I personally don't. I offer people the options for people who want to avoid Pitocin for whatever reason, because they have concerns or, things like that, then breaking the water, because it's going to break at some point anyway. Mm-hmm. And it's not common that it breaks all the way at the end. Like usually it breaks at some point during the labor course. Then that's certainly an option. I don't like to do that very early in the labor process because it increases the risk of infection. Mm-hmm. So I definitely like folks to be a little bit more, like 5-6 centimeters. And then if there's no change after a significant amount of time, then we can talk about it. But really, there's not a standard one or the other. It really just depends.
I remember with my second was such a different thing. It was so quick. It was awesome. But my first, I remember kind of talking to my midwife, like I'm sitting down looking at her. I'm like, should we break my water? Cause I was just at that point exhausted. I'm like, we have to move things. And she was so honest with me. She's like, I think your son's head is asynclitic. We have to try to adjust him because if we break the water, there's less buoyancy to try to get him to move. And there's a moment, it was like this deep pit in my stomach. I'm like, I know. So is that something you try to get people to, if you think baby might be malpositioned, to use that support of the fluid before breaking the water?
Oh, yeah. And you definitely should not break the water when the baby is high in the pelvis. That's dangerous because the cord could come down. Yeah, the cord could prolapse first. But sure, absolutely. We try to do some position. We want the head to be nice and ideally well applied to the cervix and the baby down in the pelvis before we break the water. If those things aren't the case, then we want to try and wait.
That is so smart. So you'd mentioned the peanut ball, and I'd mentioned it a couple of times, and I realized we might have listeners that are like, what is this peanut ball in which they speak of? So can you describe it a little, and then how you and your nurses use it with the people?
Sure. So it literally looks like a giant peanut. It's probably about 5 feet long maybe, and it looks like a peanut, and you can put it in between your legs. And it helps to just hold your pelvis open, and you can do different positions with it. The nurses are way better. I don't know all of the positions and things that they try.
You just walk in, you're like, oh, there it is. There's the peanut ball.
Yes, her leg is this way. We're moving that way. So it helps to open the pelvis and create space, because literally millimeters can make a difference in terms of whether or not a baby will fit or not.
Yeah, and every little bit helps. All right, we're going to take a super quick break, and when we come back, we're going to keep talking about what to do when labor is long. We'll be right back.
This episode is brought to you by Liquid IV. When you hydrate with Liquid IV, you're powered by Hydroscience. Hydroscience is Liquid IV's science-backed formula with an optimized ratio of electrolytes, vitamins, and nutrients. Experience great-tasting hydration for mental clarity, physical endurance, and overall well-being. Sip into something that up-levels every moment. Liquid IV. Tear, pour, live more. Visit us at liquidiv.com.
Walmart Business is in the business of saving you time, money, and hassle. Whether your business started in a garage or is a garage, Walmart Business has the tools to help you get where you're going. Tools like free shipping, multi-user accounts, and just about any item your company needs.
Even a double filtration cyclone dust collector.
Yep, even that.
Sweet.
Walmart Business. It's the Walmart you love. Now for your business. Learn more at business.walmart.com. Terms apply.
Okay, we are back. All right, so you have given some great information about, so we've got the peanut ball, we've got different positions, we've got pit, we've got, what was the other one you said? Breaking the water.
Breaking the water. Mm-hmm.
Is there anything else that you think could help facilitate moving things along, or it's just time?
Yeah, I was scared to say. The other thing is you can always decline to have a cervical exam at 2 hours. Like if you have a provider who wants to do cervical exams every 2 hours, that's really too soon, in my opinion. It really should probably be like every 4 hours, 4 to 6 hours that we're doing cervical exams. So you can certainly ask for more time to wait and do an exam and kind of see where things are.
Yeah. And I think, and then imagine if someone is watching their labor go slowly forward, the anxiety that's producing.
Mm-hmm.
So what are ways that if someone is feeling that pressure that, okay, I've been in here, the hospitals have certain schedules. How does somebody give themselves a little bit more time and not feel that pressure?
Yeah, I think one of the most important things is to educate yourself about the process of labor so that you know these things going into it. So many people, I've heard stories of that first cesarean birth where it was like, well, they just said that, I was 3 centimeters and I had to get a C-section. So not knowing what labor can be like. So really doing some sort of childbirth education so you understand and you can bring that knowledge to the conversation. Having someone with you who can support you and advocate for you on your behalf if you aren't able to do so because you're in the throes of labor. So whether that's your partner, whether or not that's a doula, can certainly be very helpful. A doula can be quite helpful in helping you navigate, like, maybe we should have more time. And then just being comfortable and confident and advocating for yourself that, hey, as long as my baby is doing well, I would like to wait and see how things go. And what you want to do is ask those questions during your pregnancy and not wait and for it to be a surprise as to who's going to be here during my birth. That's where a birth plan can help. So many people think a birth plan is something that you print and you bring to the hospital, and that's not what it should be. It's really an opportunity to discuss what you want for your birth. Make sure the people who are caring for you are going to be able to support that.
Yeah, I guess one of the questions that people, when they're having that conversation is, how long can I labor? If I'm okay as the birthing person, the baby's okay, why do we have time restrictions?
Yeah, and that's always a challenge because at some point, I mean, we know that some babies are not going to be born vaginally. Right. That's just the reality of things. And we also know, we don't see this very often in the U.S., but in places, in developing places, you can see things where people have had an arrested labor and it's been like that for days sometimes. That results in significant injury, bladder injury, rectal injury. So there is danger to going for very long periods of time.
So what are you considering? Yeah, this is exciting. Actually, I want to talk about the risk, not exciting as someone as bladder, but like I wanted to get into the risks and the benefits. So let's jump in there. So what are we considering long labors? Cause I've actually heard, I've never attended and I heart goes to the people that their bodies have endured this like 4 or 5 days of labor. I can't even imagine
what that does to somebody's body and mind and even their soul. It seems so hard.
Yeah, some people do have long labors like that. And it's really, it's important to break it up between the active phase or the first stage and
or
the
just
second
like the
stage.
Prodromal,
Yes,
kind of drag.
Exactly. So most of the time when people have those 4 and 5 day labors, it's because they've been in the early part of labor for days. The active phase from 6 centimeters on, that part doesn't last as long. Roughly, pretty reliably, you're going to dilate roughly about a centimeter an hour. Sometimes it's 2 hours. Sometimes it's a bit longer, and we may have to do Pitocin and things like that. But that's not going to be after 6 centimeters. It's not going to be days after that. And definitely not going to be once you're completely dilated, so 10 centimeters, excuse me, in the second stage of labor, which is from completely dilated to pushing, that we start to reevaluate at 4 hours of pushing. And then probably the longest that I've seen somebody push is, and I don't want to freak people out because this doesn't happen very often, it was 8 hours of pushing.
Okay, let's unpack that for a second. Woo. Okay, so 8 hours. That were there breaks to rest?
She took some breaks,
and eat?
But honestly, people at that point, you'd be surprised they're not hungry.
Yeah, but like something in her mouth, like anything for energy.
Yeah, I mean, just drinking. She was pushing for most of that time.
My gosh, my heart goes to that person. Did it end up vaginal?
Vacuum.
Okay,
so had to help that last little bit because it was just a lot. Yeah.
Okay, so that makes me think of the risks and benefits again. So I'm just thinking the pushing for that long, what it would probably do to someone's pelvic floor and their abs. So let's go there. And we can go like the risks and benefits of first stage and second stage. I know I'm throwing a lot at you. I hope you're okay with that.
I wouldn't say that there any the benefits of a longer labor. The biggest benefit is at the end you have a vaginal birth. So other than that, I can't say that there's anything that's beneficial. Yeah. So the risk we do know are more, there's a higher risk of postpartum hemorrhage. There's a higher risk of having a shoulder dystocia where the shoulder gets stuck under the pelvic bone, a higher risk of having swelling just from the baby being down there longer. Those things don't usually happen. So they're not common just because your labor is longer that they happen, but there is a higher risk of those. All of those things can happen with a short labor too. So it's not like a short labor prevents you from having any of those things. It's just less likely.
Is the postpartum hemorrhage, and I'm totally shooting off the hip for this, is it because maybe the uterus is tired, the muscle is tired?
100%.
Oh, okay.
Yes. Yeah.
I'm just thinking of this like little muscle, like I'm squeezing, I'm pushing, and I'm so tired now. Okay.
Yeah, 100%.
I was wondering about that. All right. So what about now the risks of long pushing, and let's also define what a long second stage is, because I do believe, and again, correct me if I'm wrong, that ACOG adjusted the pushing phase where they're saying kind of what's in the realm of normal, especially if someone has an epidural.
Yeah, with an epidural, 4 hours of pushing for first baby. With an epidural, 3 hours of pushing if you've had a baby before. That's dropped down if you don't have an epidural, but I think we all pretty much go by 4 hours, I should say where I practice anyway, by 4 hours regardless of whether or not you have an epidural. And that's just a time point to assess. It doesn't mean that you have to have a cesarean birth. That's why the person who was like pushing for so long, progress was being made. It was slow, but as long as progress is being made, you can continue to push beyond 4 hours. You don't have to stop pushing. That's just a time to reassess.
I still am just in awe of that person. You go, friend, who pushed for 8 hours.
And then on the flip side, I should say, sometimes it may be like 2 hours of pushing and literally the baby has not moved one at 1 millimeter in 2 hours of pushing, then there's a conversation. Sometimes it's like, well, you've been pushing and you're giving really good effort. Oftentimes you can feel just the way like the baby's just coming up against the pubic bone. Typically they're still high in the pelvis, but there may be instances where sooner, like at 2 or 3 hours, that it's like, well, we haven't seen much progress, and at least like offer a cesarean, not necessarily recommend, but offer a cesarean, because sometimes people get tired and exhausted and all of those things.
Yeah, I mean, pushing, from what I've observed from my own births, it's a lot of effort. I mean, for some people, it's not. I know I've had some clients that have said it was actually their favorite part of birth. I've had some clients that said it was exhilarating. They felt like they were really in their body and participating. So I don't want to ever paint the picture, but I'm going to go from my own lens that it was tiring. It was very tiring.
I think I would say after 3 hours, most people are tired because it's a lot of work.
Yeah. My daughter came out in 6 minutes. My son took almost 5 hours.
Okay.
So they were, that was quite exhausting. But yeah, I've actually seen people just like, I had one friend after, she said, that was amazing. I can't wait to do that again.
Oh gosh.
Like, you are a rock star. All right. So if that's coming up, someone's hit 2 hours and they've tried, things aren't moving, what are the suggestions? Like try different positions, or is that already in consideration during that process?
It may be, but we pull out all the stops. Have we tried spinning babies? Have we tried pushing on our hands and knees? Have we tried on the side? Have we tried tug of war? Have we tried the handles? Have we, so we go through literally every single thing we know how to do in order to try to help facilitate baby coming.
Yeah. And sometimes baby might know better. They might.
Sometimes. Yes, exactly.
They have their own will.
Yep.
So we were talking about that term failure to progress. And the thing that makes me feel is just the word failure, especially if someone ends up having a cesarean and they're wanting to have another birth. It's like this weight carried on them if they want to have a VBAC. So what do you think is another way? You talked about changing some of the wording or just another frame.
I never use the term failure to progress. I usually say arrested labor. So that just means labor stopped, and not anything that her body necessarily did wrong, or even more specifically, if it's arrest of dilation, so arrest of cervical dilation, the cervix stopped dilating at 6 centimeters or whatever it is, and what that number is. So I like to say arrest of labor.
So if you have somebody you're working with, or somebody, because again, you're not, as a hospitalist, you don't have that private clientele. If someone comes in and says, I am going for a VBAC, I didn't progress further, and you can get a sense that they want this, but there's also maybe some question. They're a little insecure, thinking, oh my gosh, my body didn't do this the first time. What ways do you think people in the staff and the support team can give some confidence if they're going for it, but in the back of their mind, they'd be like, well, my body didn't do it before.
Sure. So number one, don't use any of those VBAC calculators. They're all trash. They inaccurately take into account things like race and ethnicity, and they're not right. Like I've seen people that had a calculated chance of a successful VBAC of like 6%. And you would think, oh my goodness, it's not going to happen. And it happens. The honest truth is that most of the time it's because the baby was just coming through in a way that it wasn't quite right. And if we try again, most often you're going to be successful, even if things didn't happen the first time. Probably the biggest example for me, I had a patient who had a C-section. It was at like 35 weeks. So baby was smaller. And it was a failed vacuum birth. So they tried to vacuum the baby out. Baby wouldn't come at 35 weeks. She came back for the next pregnancy and wanted to do a TOLAC. And she was like 38 weeks. And I was like, well, baby didn't fit 35 weeks. I guess we'll see. When I tell you that this baby slid out of her vagina with no problems, that we know nothing until we try. And that's the honest to God truth. We have no accurate way of predicting what will happen until the baby tries until we try. There are some cutoffs where we recommend if a baby is particularly big, but really it's like 10 pounds. It's big, 10 and a half before we say, hey, maybe this baby won't fit. But other than that, we don't know. And you don't know until you try.
Oh, I love. Let's highlight that again. We don't know until we try. Because I've had students say, especially I have one right now. She actually had her first, I think it was actually around 35 weeks. So she's almost 39. And it was a surprise. It was not like it was very early, and she ended up having a cesarean, and now they're telling her baby's big, and she is terrified because she's hoping to have a VBAC. And so I'm just trying to remind her, like, do everything you can. And then again, sometimes it's out of our control, but I like that confidence of, we don't know until we try, because she's already feeling this pressure, like her body wasn't able to do it the first time. So what about if someone wants a VBAC and their care provider, and it was because maybe that failure to progress or arrested labor, it wasn't any other reason, or maybe it was even like a breach or something totally out of the labor picture or previa, and someone wants to VBAC, but they're finding that they can't find a care provider that supports that. What are their options, do you think?
Yeah, that's tough. I mean, definitely try your best. Your best bet is really, if you can, even if you have to travel, I would say within an hour of where you live, to find someone who's more supportive, to find a supportive practice, because that's really important. And hospital, that's the other thing, because some hospitals don't permit it. So even if you can travel, I'd say within an hour, maybe even a little bit, hour, 15, 20 minutes, then that would be the first thing ideal. If not, then definitely I think a doula would be very helpful, and a more experienced one. Who can help you and support you and understand and be ready to help advocate for you if need be. You really need to have understood childbirth education and done your homework and research about VBAC so that you can come in prepared with information and be ready to advocate for yourself. And I would say have as many conversations as possible during pregnancy, so that it's not under circumstances where there's no pressure, there's no, those kinds of things, where you can try to walk through some scenarios of how things might happen. One that I've seen, and I learned this from VBAC Link, which is like a page that does a lot on Instagram. They have a lot of stuff about VBACs. Like there's VBAC tolerant and then VBAC friendly providers. And you really want to VBAC friendly. VBAC tolerant providers may say things like, well, only if you go into labor by 39 weeks. I call it
the bait and switch. I see that a lot.
Yeah. So you want to ask those questions ahead of time, or they don't feel comfortable doing any type of induction method, which it does not have to be the case. So ask as many questions as you can during the pregnancy.
I feel like this is now the second time it's come back to have a talk during pregnancy, because during labor is not the time to be negotiating.
Nope. No. So, not if you can help it. Yeah.
So what about for people that end up using someone like you, a hospitalist, so they haven't had a chance to have that kind of conversation?
Yeah, so that's when you ask the question during pregnancy is, who are the providers? And this is something that I teach in the free class I have on making a birth plan. Who are the potential providers that could be there during my birth? And how do they practice compared to what I want? So then they can have a discussion about, we have hospitalists and here's how they are. And you can ask specifically, is there anybody who doesn't, who practices outside of what I may be looking for? And because we know sometimes that there are people who practice differently. So you just have to be specific about the questions. Now, can that be I can't guarantee anything. And your provider may not answer honestly. I can't, guarantee how they answer, but they definitely can't answer if you don't ask the question. So you at least have to ask and, give it the best opportunity to learn all of that information ahead of time.
Oh, yes. Education really is the foundation, because you don't know what you don't know. And if you walk in just thinking, I'm going to hand this over, it emotionally can be quite scarring on the other side, and you can get that loss of autonomy. And that can be, that can be hard.
100%. Yes, for sure.
All right, we're going to take a quick break, and we come back. If you want to give one tip or piece of advice you'd like to offer new and expectant parents, and also I usually ask, is there anything that I should have, anything on this topic that I forgot to ask? So we're going to take a quick break. We'll be right back.
Another switchback. Wait, this isn't the top. Where's the summit? Why am I doing this?
At REI Co-op, we believe there are places within ourselves
Almost there. You got this.
that we find only outside.
Wow. This is worth it.
We have the gear, inspiration, and advice to help you get there. REI Co-op. Visit rei.com.
Okay, we're back. So let's go to my first question. Is there anything that I forgot to ask on this whole topic of, I love that this turned into also a VBAC conversation. So on failure to progress now, we're going to call it arrested dilation, or VBAC that you think is important for people to consider.
Just take away that your body's not a failure. Like, you grew a whole human being. That cannot possibly be a failure. So there's nothing that's a failure because of the way the baby comes out of your body.
Absolutely. I also feel like there has been a shift in celebrating that. And just my time in the whole perinatal world, I feel like for a long time it was saying like, unmedicated vaginal is the way to go. And I really am proud to see there has been a shift of, you have choices and there is no failure, and acknowledging that sometimes, again, baby has a better idea of how it needs to be safely born.
Yeah, exactly. Or even these days, to the point, some people even choose to have an elective cesarean birth. That was something that I had to come to terms with, like, why would you choose that? But really, the birthing person should have choices about what they want for their experience. I think that's the key.
Yeah, because it's their experience. It's, at the end of the day, who's the one living with that story? It's them.
Yep. Yeah.
So is there one piece or tip of advice or I can't even speak today. Let's try that again. What is one tip or piece of advice you would like to offer new and expectant parents?
Do childbirth education. You have to find whatever works for you. There are lots of different options out there. Of course, our in-person options are limited, but please do some childbirth education. You're not going to get it in your appointments. I can tell you that right now. Like, doctor's appointments are typically like 5 minutes. They're not lengthy. You'll probably get more with a midwife, but with physicians, you're not going to get a lot of education. So take some time to do childbirth education. And it doesn't have to be overwhelming. Like, you don't have to spend like hours and hours and hours and hours. I really think a solid 8 to 10 hours during the whole pregnancy can help you just immeasurably in terms of being prepared and ready and empowered to advocate for yourself.
Oh, yes. Advocate for yourself, educate, which leads me to, where can people find your work?
Yes. So I am everywhere at Dr. Nicole Rankins. So Instagram is my favorite social media platform. So I'm there at Dr. Nicole Rankins, and my website is drnicolerankins.com. I have a podcast called All About Pregnancy and Birth, and a childbirth education class, a virtual childbirth education class called the Birth Preparation Course. But you can find all that at my website.
Yeah, and that is how you have time for all this, because you are a hospitalist. I'm just so impressed by that.
Yeah.
Oh, that schedule. I have to admit, I kind of envy that. Oh, it has been such a joy to speak with you again. I just really appreciate your open-mindedness and down-to-earth way in which you present information. It's just so unbiased, and you're like, here it is. You do with it what you want. I appreciate that.
Thank you. Thank you.
Well, enjoy your day.
All right, you too.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.